Hi, I'm a trainer and consultant specialising in dealing with difficult, disturbing and dangerous behaviour, and this video is based on my book, Facing Danger in the Helping Professions. You can find out more about the book at facingdanger.com, order it from Amazon, or learn more about our specialised training at dangerousbehaviour.com. Today, I'd like to talk about the face-to-face interactive skills in managing acute florid psychotic behaviour, where that behaviour involves a potential for violence. The purpose of this video, however, is not to suggest that psychotic killers lurk around every corner. 80% of violent crime is unrelated to mental illness, and the link between psychotic conditions and violence is extremely tenuous. Furthermore, where a correlation does exist, it is mostly down to alcohol and substance misuse. Indeed, according to Dr. Sina Fazel, who specialises in the relationship between mental illness and violence, it is probably more dangerous walking outside a pub on a late night than walking outside a hospital where patients have just been released. That said, the coexistence of a psychotic condition can add considerable complications to the management of violent behaviour, and this is an area where many mental health and enforcement professionals feel ill-equipped and underskilled. The first point is that when a person is in an acute psychotic state, it does not follow that the psychosis is driving the violence. Indeed, in most cases, it will be the heightened levels of agitation, arousal and emotion that will drive the behaviour. In these cases, in line with the instant aggression model, diffusing skills, de-escalating skills and rapid reaction skills, depending on the immediacy and dangerousness of the behaviour, will be appropriate. Details of these can be found in the book and are in any case the bedrock to any intervention with a person in a psychotic state. The psychosis containment skills that we will be looking at here are not alternatives to those, but supplementary to them. So how can we tell whether the behaviour is dysphoric, that is driven by emotion, or psychotic, driven by disturbance? The eyes are a good first place to look. Are they wide open, dilated, and darting rapidly? If they are hearing voices, they may place their hands over their ears to block them. They may shout back at them, their attention may shift rapidly as if they had just heard something, and they may engage in a one-way conversation. Their body is also likely to be in a state of extreme agitation, and they may rock back and forth and pull at their clothes. Their speech will also provide strong clues. Dealing with disturbed aggression is only different from reactive aggression if the primary drivers of the behaviour are the hallucinations, delusions and paranoia. Of these, the delusions and paranoia are cognitive states, and as such tend to be slow acting, while the hallucinations are perceptual and their influence can be pretty much immediate. The principle is always to focus on the aspects of a person's condition that change fastest. In this case, it's the hallucinations. The tactile hallucinations, which are usually related to a chronic illness, the removal of a dependent substance or delirium, and the visual hallucinations, which are usually related to ingesting or injecting psychoactive substances, can be fear or panic inducing and are usually only dangerous to the patient themselves. It is the auditory hallucinations that tend to be implicated in dangerous behaviour towards others, particularly if these are of a command or persecutory variety. The task, therefore, is to block the auditory hallucinations and get in front of the delusional or paranoid states. Whether the voices have an internal locus of control, that is, they hear them as originating in their head, or an external locus of control, they hear them as coming from outside, there is no specific hearing impairment related to the psychosis. They can hear as well as the next person. It is their interpretation of what is being said that is in question. Furthermore, it is not necessary to know the content of the voices, only to be able to stop them from taking control of the person's behaviour. In a similar way, The psychotic state is not a separate and discontinuous world, and the person in that state will still be aware of their environment. The problem is more likely to be that they will be experiencing great difficulty knowing what parts of that environment to trust. We now know that as the psychotic drivers take over, the thalamus, the part of the brain responsible for selective attention, reduces in size. This means that the person cannot filter out as much stimuli as usual, and so it is important to reduce distractions and focus their attention in order to avoid triggering catastrophic reactions. When a person experiences a change in their environment, such as our arrival on the scene, they have to make sense of that change. Who are we? Why are we there? And what are we going to do? The psychosis actually makes this a slow and laboured process, and this offers an opportunity to intervene before the psychotic material sets in. Finally, it is important to recognise that the person may experience significant difficulties in determining where their body ends and their environment begins. This may result in their personal space being extended, and this needs to be respected. Sudden movements and physical interventions are therefore extremely hazardous, and even more so if the person is in a state of excited delirium. So now we have briefly surveyed some of the critical issues that we need to consider in identifying the psychosis containment skills. These will be covered in part 2 of the video, and I look forward to seeing you again then. You can find further information on this and all other aspects of dealing with dangerous behaviour in Facing Danger in the Helping Professions by Iain Bourne and published by the Open University Press.